Welcome, everyone, to the Deep Dive Ortho, where we unravel the intricacies of orthopedic challenges. Today, we're plunging into a truly critical and, let's be honest, often complex area for any medical professional:
Right.
acquired hand deformities. These conditions, as you know, aren't just cosmetic, they can profoundly disrupt a patient's daily life and functional independence. Getting that diagnosis right and getting it right early is paramount. Just imagine the human hand for a moment. It's a marvel of engineering, isn't it? Capable of such intricate tasks, from simple things like tying a shoelace to, well, performing delicate surgery. But when something goes wrong, it's not just a physical problem, it's a profound disruption to a patient's entire world. So, our mission today is to really dissect one of the most intriguing and functionally quite devastating of these disruptions: the Boutonniere deformity. Joining us to navigate this intricate subject and to shed light on its distinctions from other common presentations you will undoubtedly encounter in practice is our expert guide. Welcome.
Thank you. It's a pleasure to be here to discuss this important topic.
Great. Professor, let's unpack this right from the start. Acquired hand deformities. They're far more than just surface level issues, aren't they?
Oh, absolutely. Far more.
They represent significant structural or functional abnormalities that can severely impact a patient's quality of life. I mean, we're talking everything from basic grip issues to a complete inability to move a finger. What exactly defines an acquired hand deformity in this context, and what are the broad categories of causes you typically see?
Right. Well, when we talk about acquired hand deformities, we're specifically differentiating them from congenital conditions, things people are born with. These are structural or functional abnormalities that develop in the hand over time, often, as you say, as a result of an injury or perhaps an underlying disease process. And you're absolutely right. These are rarely minor inconveniences. They can trigger a whole cascade of significant consequences and complications for the patient. Understanding the etiology, the why behind it, is genuinely the first crucial step towards effective management and hopefully restoring function. So we can broadly categorize the causes into several key areas. First, and probably foremost, trauma is a primary culprit, a huge factor.
Right.
This covers everything from a direct blow, think of a classic jam finger in a sporting event, basketball perhaps, to much more severe incidents. I mean, I've seen countless cases where a seemingly innocuous fall onto an outstretched hand, or maybe a deep laceration from a kitchen knife, even significant burn injuries can set off this chain reaction leading to deformity.
Burns especially, I imagine.
Yes, burn trauma can be particularly devastating. It can cause severe contractures, even webbing between the digits, what we call syndactyly, which fundamentally alters the hand's architecture and function. And thinking about high-energy impacts, say in contact sports, it might not just break a bone. Crucially, it can damage the delicate tendon structures, leading to a progressive deformity if it isn't addressed promptly and correctly.
Makes sense.
Then, beyond those acute events, inflammatory conditions play a huge role. Rheumatoid arthritis, for instance, is a major contributor. As you know, this is an autoimmune disorder. The body's immune system mistakenly attacks its own healthy cells, and it particularly targets the synovium, that's the membrane lining our joints. Over time, this chronic inflammation leads to the formation of a destructive, abnormal tissue layer. We call it pannus, which effectively invades the joint space. This process systematically erodes cartilage and bone. The result: intense pain, swelling, stiffness, and ultimately often severe and truly debilitating hand deformities.
And it's not just Arave, is it?
No, not at all. Other inflammatory conditions like gouty arthritis that's caused by monosodium urate crystal deposits leading to tophi formation, or systemic lupus erythematosus, another autoimmune issue, can also induce inflammation and subsequent tissue and joint damage throughout the hand, including those delicate finger structures.
Okay, so trauma, inflammation.
Yeah.
What else?
Then there's degenerative arthritis, and specifically osteoarthritis. Here, the fundamental issue is the gradual wear and tear, the deterioration of the smooth cartilage within a joint. Eventually, the underlying bone gets exposed. It's a progressive disorder, meaning it generally worsens over time. Its symptoms can range from initial stiffness and pain, which might be manageable at first, to a really significant impairment in hand function later on, making even simple daily tasks incredibly difficult.
Where do you typically see OA changes in the hand?
We commonly observe this at the base of the thumb. The carpometacarpal or CMC joint is a classic site, and also in the interphalangeal joints, both the distal DIP and proximal PIP ones. You might actually see the growth of osteophytes, those characteristic bony enlargements. They form what are known as Heberden's nodes at the DIP joints and Bouchard's nodes at the PIP joints. These aren't just cosmetic issues. They're often palpable, sometimes quite painful, firm swellings that directly restrict movement.
And the final category.
And finally, we shouldn't forget neurological disorders. These can also be a significant factor. Cerebral palsy is perhaps a prime example. Patients with CP often experience spasticity, which is essentially increased muscle tone and stiffness. This spasticity, if it's left unmanaged, can progressively limit the range of motion in the hand, leading to quite debilitating hand contractures over time. Think of muscles constantly pulling, shortening, and eventually fixing joints in abnormal, non-functional positions. So you see, the consequences of all these diverse causes can be acute, limiting immediate movement and grip straight after an injury, or chronic, progressively impairing joint function and ultimately leading to significant functional limitations. It really can fundamentally alter a patient's ability to interact with their world.
It truly sounds like a broad and impactful category, Professor. Diverse presentations, each carrying potentially profound consequences for the patient's independence. Before we really home in on Boutonniere deformity, could you perhaps briefly paint a picture of some of the other common acquired hand deformities we might encounter in clinical practice, just to give our listeners that wider context, that landscape?
Certainly. Yes, beyond the immediate causes we've discussed, it's helpful to recognize the sheer spectrum of acquired hand deformities that can present clinically. For instance, we frequently encounter Duthertrend's contracture. This is a rather curious condition. It's characterized by the thickening and tightening of the fibrous tissue layers, the fascia, in the palm. This eventually pulls the fingers, usually the ring and little fingers, into a permanently flexed, bent position towards the palm.
And the cause is still a bit unclear.
Its precise causes remain somewhat elusive, yes? There's a strong genetic component, but it's a common presentation, particularly among individuals of Northern European descent, which is why it's often informally called Viking disease.
Yeah.
Imagine trying to place your hand flat on a table, but your fingers are just stubbornly curled inwards. That's Dupuytren's. Then there's gamekeeper's thumb, sometimes also known as skier's thumb. This involves damage, usually a tear, to the ulnar collateral ligament of the thumb, specifically at the MCP joint. That's a crucial stabilizing structure for pinch grip. Damage here significantly diminishes a patient's ability to grasp or pinch effectively.
Acute or chronic?
It can be either. Often an acute injury, maybe from a fall where the thumb is forced outwards, like falling on a ski pole, or it can result from chronic overuse, hence the gamekeeper name. Historically, gamekeepers apparently injured this ligament while, dispatching small game.
Grim, what else?
Well, as I touched upon, hand osteoarthritis deformity. This manifests as those structural changes in the hand joints from OA, commonly affecting the thumb base, the DIPs, and the PIPs. Leads to stiffness and those characteristic bony enlargements we mentioned, Heberden's and Bouchard's nodes. Mallet finger is another very, very frequent occurrence, often seen in A&E departments.
Ah, yes, the droopy fingertip.
Exactly. It results from an injury to the thin extensor tendon that straightens the very end joint, the distal interphalangeal, DIP joint, of a finger. A common mechanism is a jamming injury, maybe catching a ball awkwardly, which ruptures the tendon, or sometimes even avulses a small bone fragment from the distal phalanx. It leaves the fingertip, with that characteristic droopy appearance, unable to fully extend on its own. And of course, the swan neck deformity, which I know we'll delve into in more detail later as a comparison to Boutonniere, visually it's quite distinct. It presents with the proximal interphalangeal, PIP, joint hyperextended, so straightening out or even bending backwards, and the distal interphalangeal, DIP, joint flexed, bending inwards. Creates that distinctive swan's neck profile.
Often linked to RA as well.
Very often linked to rheumatoid arthritis, yes, but it can also stem from other causes like ligament laxity or specific tendon tears. Finally, worth mentioning, ulnar claw hand. This is a significant deformity caused by ulnar nerve damage, perhaps from an injury at the elbow or wrist. It leads to numbness, often pain, hand weakness, and a characteristic claw-like posture. The ring and little fingers are typically bent or flexed at the PIP joint and hyperextended at the MCP joint, making it very difficult to straighten them.
Okay, that's a helpful overview.
And while these conditions are clearly diverse in their specific pathology and appearance, what's crucial for clinicians is that they often share common diagnostic principles. And, in many cases, they overlap in their initial conservative treatment strategies within orthopedic practice. But crucially, the subtle nuances in their underlying mechanisms truly dictate the specific, definitive approach needed.
That's a comprehensive tour, thank you. Now, let's really zoom in on Boutonniere deformity. From a clinical perspective, what makes this presentation so distinct, both visually and functionally? And what exactly is happening at the anatomical level to cause that very specific buttonhole appearance? It's quite a puzzle, isn't it?
It is indeed a fascinating biomechanical puzzle, and clinically, it's quite distinct once established. A Boutonniere deformity is defined by a very specific and really quite telltale posture of the affected digit. The proximal interphalangeal joint, the PIP joint, that's the middle joint of the finger, remains permanently bent towards the palm. That's flexion. Simultaneously, the distal interphalangeal joint, the DIP joint, the one farthest out near the fingertip, goes into hyperextension. It bends back away from the palm. This combination gives the finger a somewhat distorted appearance, often likened, as you say, to a buttonhole, hence the French name boutonniere.
And it can affect the thumb, too.
Yes, that's an important point. While we commonly discuss it in the context of fingers, a boutonniere deformity can also affect the thumb. It presents slightly differently due to the thumb's anatomy, but typically as flexion at the first joint, the MCP joint, and hyperextension at the outermost joint, the IP joint.
Right. So let's get into the mechanics, the pathophysiology. Understanding the how must be crucial for fixing it.
Absolutely crucial. Let's delve into the detailed pathophysiology. Understanding the precise how behind this deformity is key for effective intervention. Imagine your finger's top surface, the dorsal side, almost like a finely tuned puppet string system. The primary event, the trigger, is an interruption of the central slip of the extensor tendon. The central slip is a key component of the extensor mechanism running along the top of the finger. It's the direct connection responsible for extending or straightening the PIP joint. It inserts right onto the base of the middle phalanx. Now, when this central slip is interrupted, maybe it's ruptured by a direct blow, perhaps it's lacerated cleanly by a sharp object, or maybe it's avulsed, meaning it's torn off the bone. Sometimes taking a tiny fragment with it, you lose that direct extrinsic extension force at the PIP joint. The PIP joint simply cannot be actively straightened anymore by the main extensor muscle pulling from the forearm.
And that's just the start of the problem.
Exactly. That's just the beginning. What happens next is a cascade, a sequence of profound biomechanical imbalances. Without the normal stabilizing and extending pull of the central slip, two other crucial structures, the lateral bands, the extensor tendon, start to misbehave. Normally, these run neatly along the sides of the PIP joint, staying dorsal, and they primarily contribute to extending the DIP joint further down. But now, they lose their dorsal anchor provided by the intact central slip system. As a result, they begin to slip volarly, that means towards the palm side, relative to the PIP joint's axis of rotation.
What allows them to slip like that?
Well, this volar migration is significantly facilitated by the attenuation or weakening and stretching of the triangular ligament. This is a tiny but vital stabilizing strap located just distal to the PIP joint over the middle phalanx. Its job is normally to keep these lateral bands securely in their dorsal position. When the central slip goes, the forces change, this ligament stretches or tears, and the lateral bands are free to subluxate volarly. Think of it like a rope designed to pull something straight up, suddenly sliding underneath the pulley. Now, instead of pulling up, it starts pulling down.
Ah, so they start acting as flexors.
Precisely. As these lateral bands migrate volarly, they fundamentally alter the biomechanics of the hand's intrinsic muscles, particularly the lumbricals and interossei. These small muscles within the hand typically have a dual role, helping with both PIP flexion and DIP extension, depending on the joint position. But critically, with the lateral bands now pulled volar to the PIP joint's axis of rotation, the pull from these intrinsic muscles effectively becomes purely flexing at the PIP joint. They actively pull the middle joint into that fixed, bent position. Concurrently, because these same intrinsic muscles insert on the base of the distal phalanx via these now displaced lateral bands, and without the balanced opposing force from the central slip acting correctly at the PIP, they then hyperextend the DIP joint. It's a complete biomechanical chaos stemming from what might seem like a single point of failure in that central slip. A real domino effect, absolutely. And from a bone perspective, the injury functionally involves all three phalanges of the digit. The middle phalanx is drawn into flexion relative to the proximal phalanx at the PIP joint. And conversely, the distal phalanx becomes hyperextended relative to the middle phalanx at the DIP joint.
You mentioned it's common in RA. How common are we talking?
Yes, in terms of epidemiology, Boutonniere deformity is notably prevalent in specific patient populations. It's particularly common, as you say, in individuals with rheumatoid arthritis. Various studies indicate that up to 50%, perhaps even slightly more in some cohorts, of patients with rheumatoid arthritis may develop a Boutonniere deformity in at least one digit. This is due to the ongoing destructive inflammatory processes affecting the soft tissues and joints. That's a significant number, and it really underscores the importance of diligent screening and early recognition in these patients.
Professor, that detailed breakdown of the anatomical changes, that domino effect, is absolutely crucial. Thank you. Now, let's connect that complex pathophysiology back to the real-world scenarios. What specific events or underlying conditions typically trigger this precise sequence of anatomical changes you've just so clearly described? And maybe more importantly for the clinicians listening, what's the most common pitfall or trap when trying to get this diagnosis right?
That's a vital connection to make, absolutely. The underlying cause often dictates the urgency of treatment and the most appropriate approach. Primarily, Boutonniere deformity is caused by trauma. As we touched on, imagine a forceful blow directly to the dorsal side, the top side, of a flexed middle finger joint. This is the classic jammed finger scenario. You often see it in sports like basketball or football, maybe netball. The impact can directly rupture the central slip, or perhaps even more commonly, it can cause an avulsion fracture, where the tendon, as it's forcefully stretched, tears a small piece of bone away from its attachment site on the middle phalanx.
And cuts.
Yes, lacerations. Things like those from a kitchen mishap with a sharp knife or maybe a workplace accident involving glass or metal can also directly sever the central slip. That leads to the same profound loss of active PIP extension. Furthermore, a dislocation of the middle phalanx, particularly if it's displaced towards the palm, volarly, can easily tear the central slip from the bone, immediately instigating the chain of events leading to the deformity.
And the non-traumatic causes, primarily RA.
Primarily. Beyond acute trauma, inflammatory conditions are significant primary causes. As we discussed, rheumatoid arthritis is the most common rheumatologic condition associated with Boutonniere deformity. The chronic synovitis, the inflammation in RA, progressively weakens and can eventually erode and destroy the central slip structure, leading to the gradual, sometimes insidious, onset of the deformity over months or even years. While less common, other conditions like psoriatic arthritis and certain genetic connective tissue syndromes, like Ehlers-Danlos syndrome, can also contribute. They essentially weaken these crucial soft tissue structures, predisposing individuals to this type of failure and subsequent deformity.
Okay. Now, about those diagnostic pitfalls you mentioned.
Right. This is critical. It's absolutely crucial for orthopedic professionals, and especially for those specializing in hand surgery, to understand and recognize a vital distinction: the difference between a true Boutonniere deformity and what's termed a pseudo-Boutonniere deformity.
Pseudo-Boutonniere, how does that differ?
A pseudo-Boutonniere deformity typically results from a hyperextension injury, so the finger being bent backwards violently, which disrupts the soft tissue structures on the palm side of the PIP joint, particularly the volar plate. This injury can cause the PIP joint to get stuck in flexion, mimicking the appearance of a true Boutonniere. However, the key difference lies in the underlying pathology. In a pseudo-Boutonniere, the extensor mechanism itself, including the central slip, is often intact. The joint is held in flexion due to injury or contracture of the volar plate, maybe some collateral ligament damage.
So the treatment would be completely different.
Completely different. Imagine a patient presents with a bent middle finger. Your first thought might be Boutonniere. But on closer questioning and examination, you realize the injury mechanism was a violent backward bend, not a direct impact to the top or a cut. This seemingly subtle difference is not merely academic, it dictates the entire treatment pathway. Treating a pseudo-Boutonniere with prolonged PIP extension splinting, like you would for a true Boutonniere, might actually worsen scarring and stiffness on the volar side. Failing to differentiate between the two can lead to entirely inappropriate management, potentially worsening the long-term outcome. So a thorough evaluation by a specialist, really focusing on the mechanism of injury and specific clinical tests, is absolutely necessary to identify the precise underlying mechanism and tailor the treatment accordingly. It's a classic diagnostic trap.
That distinction between true and pseudo-Boutonniere really sounds like it could be a genuine diagnostic minefield. So bearing that in mind, how do we effectively assess and confirm a true Boutonniere deformity, particularly when, as you mentioned earlier, the characteristic signs might not appear immediately after the initial injury? What's the clinical superpower, if you like, for early detection?
You've hit on a critical point there. Diagnosis really requires a combination of astute clinical observation, careful history taking, especially regarding the mechanism of injury, and specific examination techniques. Because as you say, the classic buttonhole appearance isn't always immediate. That delayed onset can easily mislead the unwary. Patients typically present initially with pain and swelling, usually quite localized directly over the PIP joint on the dorsal side. They'll also often report a distinct inability to actively straighten that middle joint of the affected finger. What's crucial to remember and to explain to patients is that the characteristic bent middle joint, PIP flexion, and the hyperextended fingertip, DIP hyperextension, might not fully manifest for several days or sometimes even up to 3 weeks after the initial injury.
Why the delay?
It's often due to initial swelling supporting the joint somewhat, and the lateral bands taking time to stretch and migrate volarly. This delay means a high index of suspicion is absolutely vital in cases with a relevant trauma history, or certainly in patients with known inflammatory conditions like RRA. You have to look for the potential injury, not just the established deformity.
Okay, so suspicion is high. What next in the examination?
Right. When it comes to the physical examination, we move beyond just simple observation of the posture. A thorough assessment of both active and passive range of motion is key. We'll ask the patient to try and actively straighten the affected finger. Then we'll ask them to actively bend just the fingertip, the DIP joint. We're looking for that telltale inability to extend the PIP joint actively, combined with that compensatory, often developing hyperextension of the DIP. We also assess the passive range. Can we straighten the PIP joint fully? Initially, it might be passively correctable, but it can become fixed over time.
And the superpower test.
Yes, the most reliable clinical method for diagnosing a central slip injury before the full deformity is evident, or indeed even when it is present, is the Elson test. This test really is your clinical superpower for early detection of central slip insufficiency.
How is that performed?
It's quite straightforward to do. You ask the patient to bend their PIP joint to exactly 90 degrees. Often the easiest way is by resting the proximal phalanx flat on a table and letting the rest of the finger hang over the edge. Then, while holding their proximal phalanx stable, you ask the patient to attempt to extend or straighten their middle phalanx against your gentle resistance applied to the dorsum of the middle phalanx. The positive finding for a central slip injury is very specific, and it's a two-part finding. Firstly, you'll observe weak PIP extension. The patient struggles to generate force to straighten that middle joint because the central slip isn't working. And critically, the DIP joint will simultaneously go rigid or extend. It might even hyperextend slightly.
Why does the DIP go rigid?
That rigidity occurs because, with the central slip compromised, the extensor force is being transmitted abnormally through the lateral bands. In the attempt to extend the PIP, the lateral bands tighten, and because they insert onto the distal phalanx, they pull the DIP joint into extension, preventing it from staying relaxed or floppy. In contrast, if the extensor mechanism, specifically the central slip, is intact, when the patient extends the PIP against resistance, the DIP joint should remain floppy or passively movable. The extension force is correctly focused at the PIP, and the lateral bands are being abnormally tensioned in the same way. This seemingly simple maneuver, checking for weak PIP extension and simultaneous DIP rigidity, is often the critical difference between catching the injury early, before a fixed deformity sets in, and facing the challenge of managing a much more complex chronic condition later on.
That's a fantastic clinical pearl. What about imaging?
Alongside the physical examination, complementary investigations are often necessary. They help rule out associated injuries or understand any underlying conditions. Radiographs, simple X-rays are always recommended. Mandatory, really. While they might not directly show the tendon injury itself, tendons being soft tissue, they are absolutely essential to detect any associated broken bones. We're particularly looking for avulsion fractures, where the central slip has pulled a small piece of bone off its attachment site on the dorsal base of the middle phalanx. X-rays also help us check the joint alignment and determine the severity of any pre-existing arthritis or underlying bone deformity, which is especially important in chronic cases or those with known arthritic involvement.
Ultrasound, right?
An ultrasound scan may occasionally be required. It can provide further visualization of the soft tissue damage, particularly allowing direct assessment of the integrity, or lack thereof, of the tendon itself. It can also offer a dynamic assessment, showing how the tendon moves or doesn't move during attempted finger motion. MRI is less commonly needed for straightforward cases, but might be considered in complex or unclear situations. While not directly diagnostic for the Boutonniere deformity itself, laboratory tests, like blood tests looking for inflammatory markers for specific antibodies, might be relevant if an inflammatory condition like rheumatoid arthritis or perhaps gout is suspected as a primary or contributing factor to the tendon weakening or joint damage.
Any role for nerve tests?
Generally, no, not for an isolated Boutonniere deformity. However, nerve testing, like electromyography, EMG, or nerve conduction studies, isn't typically needed for Boutonniere per se, but it might be considered if nerve damage is suspected to be contributing to a broader hand deformity picture. For example, in cases of ulnar claw deformity, which we mentioned earlier, that is associated with nerve damage, often originating from the elbow. So nerve tests help ensure we're not missing a neurological component contributing to the hand's overall functional impairment, leading to a more comprehensive diagnosis when the picture is complex.
Okay, so we've got the diagnosis confirmed. What's the typical first line of attack for managing Boutonniere deformity? It sounds like non-surgical methods are often the go-to, particularly for acute cases. Tell us about the philosophy behind restoring that delicate balance in the finger without jumping straight to surgery.
That's absolutely right. For Boutonniere deformity, particularly in acute traumatic cases, those fresh injuries, non-surgical treatment is indeed the preferred initial approach, and often definitive if started early and managed correctly. The overarching principle here is quite clear. Reduce the immediate symptoms like pain and swelling. Promote optimal healing of the injured structures, specifically the central slip, and ultimately maintain or ideally improve function. And I really cannot stress this point enough. Early treatment is absolutely critical for traumatic injuries. Starting treatment within the first week or two maximizes the potential for recovery of full range of motion and significantly reduces the risk of the deformity becoming fixed or chronic. Honestly, the longer you wait to initiate proper treatment, the more difficult and less predictable the outcome becomes. Scar tissue forms, contractures develop, and reversing those changes is much harder.
So what does that early treatment involve? Splinting, primarily.
Yes. The absolute cornerstone of conservative treatment for Boutonniere deformity is splinting. But it has to be done correctly. The methodology is very specific. The PIP joint, that middle finger joint, must be splinted in full, uninterrupted extension. 0 degrees. Perfectly straight. This crucial step is designed to do one thing: keep the torn ends of the injured central slip tendon approximated, close together, without tension. This allows them to heal effectively in an optimal, elongated position. This sustained extension facilitates the formation of good quality scar tissue and encourages reattachment of the tendon if avulsed. Think of it like putting the two frayed ends of a torn rope together perfectly aligned and holding them absolutely still while the glue sets. Any movement disrupts that process.
And how long does the splinting need to go on for?
In terms of duration and, crucially, compliance, the splint typically must be worn continuously, and I mean continuously, 24 hours a day, 7 days a week, usually for a recommended period of 6 to 8 weeks for the initial healing phase.
Wow, 24/7 for that long. Compliance must be a huge issue.
It is the single most critical factor. Patient compliance, patient understanding, patient buy-in, it's everything. We have to explain very clearly to patients that any accidental flexion of that PIP joint, even a momentary bend when the splint is briefly off for hygiene, can effectively undo weeks of healing progress. It can re-rupture the fragile healing tissue. This requires them to essentially restart the recovery clock right back to day one. It's truly like breaking that newly formed, very fragile bridge between the tendon ends.
How do you manage hygiene then?
It requires meticulous care. It's imperative that when the splint is removed for cleaning the skin, the entire finger must be supported rigorously in a perfectly straight position throughout the process of removal, cleaning, drying, and reapplication. Often, it's genuinely helpful for patients to have someone else assist them with this, especially initially, to ensure that PIP joint remains perfectly straight without any accidental bending. Resting the hand flat on a table during the change can help. After this initial rigid full-time phase of 6 to 8 weeks, we usually transition to part-time splinting. This often involves wearing it just at night, or perhaps during activities that might put the finger at risk of re-injury for an additional 2 to 4 or sometimes even 4 to 6 weeks. This protects the maturing repair while gradually reintroducing movement.
You mentioned keeping the PIP straight. What about the other joints?
Yes. Another very important nuance in splinting for Boutonniere is the management of the DIP joint, the end joint. Unlike the PIP joint, the DIP joint should not be immobilized by the splint. The splint should stop short of the DIP crease. In fact, active and passive flexion of the DIP joint is strongly encouraged throughout the entire splinting period. We want that joint moving.
Why is that important?
This active motion serves 2 key purposes. Firstly, it promotes tendon gliding of the lateral bands over the sides of the finger, helping to prevent them from becoming scarred down in their potentially displaced position. Secondly, it helps to prevent stiffness and contracture of the oblique retinacular ligament, ORL, another structure that can tighten and contribute to secondary problems, specifically limiting DIP flexion if it gets stiff. Interestingly, the ability to actively flex the DIP joint fully while the PIP remains correctly extended in the splint is actually considered a positive prognostic sign. It suggests the central slip is healing well and the lateral bands are starting to rebalance.
Are there different types of splints used?
Yes, there are variations. Custom fabricated thermoplastic splints, made by a hand therapist, are often preferred because they can be molded for a precise, comfortable fit, especially if they're swelling. Commercial, off-the-shelf splints are also available and can be effective if they fit well and hold the PIP fully straight. However, some types, like certain three-point pressure splints or ring splints, are sometimes less favored for the acute injury phase, particularly if there's significant swelling. Achieving consistent, comfortable, and truly rigid immobilization can be challenging with those types initially. They might be more useful later in rehabilitation. General advice for patients during this time also includes maintaining good skin condition under the splint, keeping it clean and dry. Regularly elevating the hand helps reduce swelling. And very importantly, actively moving all the other unaffected fingers, the thumb and the wrist, frequently to prevent generalized stiffness in the rest of the hand. You don't want the whole hand seizing up.
And activity restrictions.
Absolutely. Critically, patients must avoid any heavy lifting, forceful gripping, or movements that put direct pressure or force to the affected hand during the entire healing phase. Protect or repair.
What about therapy beyond just the splinting?
Yes, occupational therapy or physiotherapy, specifically hand therapy, is integral to the process, both during and after splinting, to maintain and ultimately improve function. During the splinting period, as I mentioned, early exercises focus on the unaffected joints. This primarily means actively bending and straightening the DIP joint of the splinted finger multiple times throughout the day, and of course, maintaining full movement in all other fingers and the wrist. Keep everything else moving. Then, after the initial 8 or so weeks of continuous splinting, and only when advised by the surgeon or hand therapist, patients begin very gentle, carefully controlled exercises to start regaining movement in the PIP joint itself. This might involve carefully controlled active and passive bending and straightening motions. Sometimes, specific tools are used, like a small metal exercise bar placed on the palm side, bent to guide flexion just distal to the middle joint crease. It provides a visual and tactile guide. These PIP exercises should be performed frequently, perhaps every 1 to 2 hours initially, but always gently and within comfortable limits, specifically avoiding any pain that suggests overstressing the healing tendon.
It's a gradual process.
And for the inflammatory cases, any role for medication?
Definitely.
For cases caused or significantly exacerbated by underlying inflammatory conditions like rheumatoid arthritis, medicinal treatments are absolutely crucial. Now, these aren't direct treatments for the Boutonniere deformity itself in terms of reversing the mechanical problem, but they are essential for addressing the underlying systemic disease process that's driving the tissue damage. This typically includes corticosteroids, often used short-term via injection or orally, to mitigate acute swelling and inflammation around the joint and tendons. More importantly, long-term management relies on disease-modifying antirheumatic drugs, or DMARDs. These are essential to help reduce the ongoing joint damage caused by the autoimmune process itself. Controlling the underlying RA is key to preventing progression or recurrence. So, really, a successful outcome, especially in traumatic cases, often hinges on a multidisciplinary approach: meticulous splinting, targeted hand therapy, excellent patient education and compliance, and, where relevant, appropriate medical management of any underlying condition. This combination offers the best chance for success and often spares the patient from needing more invasive surgical procedures down the line.
That emphasis on compliance, the meticulous nature of the splinting, and that delicate balance of immobilizing one joint while actively mobilizing another truly highlights the precision required in non-surgical management. It's clearly not just putting a splint on. But Professor, what happens if these conservative approaches aren't successful? Or perhaps if the case is particularly severe or complex right from the outset? What surgical options are available for Boutonniere deformity? And importantly, what are the realistic expectations for a patient after such an intervention?
Indeed. While conservative management is absolutely the first line for many Boutonniere deformities, especially those acute traumatic ones caught early, surgical intervention is certainly an essential part of our armamentarium. It's reserved for more extreme or specific circumstances where non-operative treatment has failed or is unlikely to succeed. Generally, we consider surgery in several situations. Firstly, when non-surgical splinting and dedicated therapy have failed to improve the condition or prevent progression, particularly if the deformity has remained untreated or poorly managed for more than, say, 3 weeks. By that point, it becomes significantly harder to correct conservatively due to the development of fixed soft tissue contractures and scar tissue.
So chronicity is a factor.
Chronicity is definitely a major factor influencing the decision towards surgery. Surgery is also often indicated when the deformity results directly from conditions like rheumatoid arthritis, particularly if there's significant associated joint destruction visible on X-rays. The underlying pathology there often requires a different approach. In acute settings, surgery is usually necessary if the central slip tendon is overtly severed by a deep laceration. If you can see the cut ends, primary repair is generally the best option.
What about fractures?
Yes, absolutely. Surgery is also vital in cases of acute displaced avulsion fractures. If a large fragment of bone has been pulled off by the tendon and is significantly moved out of its normal position, disrupting the joint surface or alignment, it usually requires open reduction and internal fixation, basically, putting the fragment back accurately and holding it with pins or screws. Furthermore, any open wounds associated with the injury that require formal surgical debridement, cleaning out dead tissue and contamination, and repair, especially to prevent deep infection, would naturally necessitate surgical intervention at the same time as addressing the tendon injury.
Okay, so if surgery is decided upon, what are the options? It sounds like there might be quite a few.
The surgical landscape for Boutonniere deformity is quite diverse, yes. There isn't just one operation. The procedure chosen is carefully tailored to the specific pathology found the cause, the chronicity, the degree of stiffness, the joint condition, and so on. For a fresh, clean laceration severing the central slip, a primary central band repair is often performed. This involves directly stitching the torn ends of the central slip back together, usually with strong sutures. If the central slip has avulsed from the bone, perhaps with a small bone fragment that's too small to fix directly, ligament anchoring procedures can be used. This involves reattaching the tendon securely back down to the bone, using tiny suture anchors drilled into the middle phalanx. For PIP joints that are dislocated and either cannot be reduced closed or remain unstable after reduction, temporary pinning across the joint is an option. The joint is carefully repositioned anatomically and then stabilized internally with 1 or 2 smooth wires, or K-wires, for approximately 6 to 8 weeks to allow the soft tissues to heal in the correct alignment before the pins are removed. These pins act like an internal splint.
What if the lateral bands are the main issue?
Good question. In more chronic deformities where the lateral bands have significantly migrated volarly and are actively contributing to the PIP flexion contracture and DIP hyperextension, specific lateral band relocation procedures might be considered. The goal here is surgical, to redorsalize them, essentially lift them back up onto the top sides of the PIP joint where they belong to try and restore a more balanced extensor mechanism. This can involve quite intricate soft tissue dissection and reconstruction. For persistent or severe DIP hyperextension that doesn't resolve with PIP correction, sometimes a terminal tendon tenotomy is performed distally. Procedures like the modified Fowler or dolphin tenotomy involve carefully releasing or lengthening the terminal extensor tendon where it connects to the distal phalanx. This helps to alleviate that backward bend at the end joint. But, and this is critical to emphasize, a central slip tenotomy is never performed. That would obviously worsen the primary problem at the PIP joint.
And if the central slip tissue is just too damaged or retracted?
It's exactly. For chronic injuries where the original central slip tissue is poor quality, retracted, scarred, or simply has too much substance loss, direct repair is impossible. In these challenging cases, tendon reconstruction or grafting becomes necessary. A significant advancement in this area, which is particularly fascinating from a technical perspective, involves the use of an autologous palmaris longus tendon graft. Autologous meaning it's harvested from the patient's own body, usually the forearm.
Why the palmaris longus?
The palmaris longus is chosen for several reasons. Firstly, it's readily accessible, and its harvest causes minimal functional deficit. It's actually congenitally absent in about 15–20% of the population anyway, and its absence doesn't significantly impact grip strength or median nerve function across the wrist. Secondly, being autologous, there's no risk of rejection or disease transmission like there might be with an allograft donor tendon.
How is the graft used?
Yeah, the process typically involves harvesting about a 6-centimeter length of the palmaris longus tendon through small incisions in the forearm. This graft is then meticulously prepared. Subsequently, during the hand surgery, small surgical tunnels or holes are carefully drilled through the base of the middle phalanx and potentially through any remaining stump of the original central slip. The harvested palmaris longus graft is then intricately passed through these tunnels, creating a new, strong central slip connection. Crucially, it's often woven or looped around the displaced lateral bands as well, effectively pulling them dorsally back into their correct anatomical position, aiming to restore the extensor mechanism's balance. Recent in vivo studies in K-series have shown really quite remarkable success with this type of reconstruction, even in chronic cases. I recall reading reports where patients were able to regain near-normal active finger straightening and could make a full fist again post-surgery, with good results maintained even at 3-year follow-ups. It's a testament to the potential of these advanced reconstructive techniques.
Are there options for very arthritic joints?
Yes. For those cases, particularly common in long-standing rheumatoid patients, where the PIP joint itself is painful, stiff, and severely damaged by arthritis, reconstruction might not be feasible or sensible. In these situations, PIP joint arthrodesis, which is a surgical fusion of the joint, may be the best option. This procedure sacrifices motion at that specific joint, but provides excellent stability and significant pain relief. The joint is typically fused in a slightly bent functional position, around 30-40 degrees of flexion, which allows for good overall hand function for grasp. Lastly, just to be comprehensive, for much more extensive non-joint related deformities, perhaps resulting from trauma like partial hand amputations with loss of digits, various complex flap reconstruction procedures might be employed. These use skin and sometimes deeper tissues transferred from elsewhere to restore some level of functional contour and covering, improving overall hand utility and appearance.
What about recovery after surgery? Is it similar to the non-surgical route?
Post-surgical protocols often involve a rehabilitation regimen that shares similarities with the non-surgical treatment, yes. It frequently includes a period of splinting, often for 6 to 8 weeks, to protect the surgical repair or reconstruction. However, depending on the specific procedure performed and the stability achieved, sometimes very gentle, protected active or passive motion might be initiated slightly earlier, always under the careful guidance and supervision of a specialized hand therapist. The rehab is usually quite intensive. It's also really important to manage patient expectations realistically. While surgery can significantly reduce pain and demonstrably improve function in many cases, it may not completely restore the finger to its normal pre-injury appearance or regain the full original range of motion, especially in chronic arthritic cases. Prognosis-wise, as a general rule, early surgical intervention, particularly for acute traumatic deformities addressed within the first few weeks of injury, generally leads to better functional outcomes.
In contrast, chronic injuries, and especially those caused by underlying rheumatologic conditions, often present greater surgical challenges due to the established tissue changes, scarring, and the chronicity of the disease process itself. These cases inherently have less predictable results. The journey back to function is often long and requires significant patient commitment, but the aim is always to restore as much valuable function to that hand as possible.
Professor, you've provided such a detailed and clear roadmap for understanding and treating Boutonniere deformity. Thank you. But as you alluded to earlier, it's a condition that's often confused in practice with another common hand condition, swan neck deformity. This raises a really important question for clinicians. How can two presentations that might at first glance seem somewhat similar, both involving abnormal postures of the PIP and DIP joints, actually have such fundamentally different underlying pathologies and consequently demand completely different treatment strategies? What are the absolute key differentiating factors that every clinician needs to have locked down?
This is indeed a vital distinction in hand pathology, yes, and one that you're right can sometimes trip up even experienced clinicians if they don't have specific training or experience in hand surgery. Getting this differential diagnosis right is critical. While both boutonniere and swan neck deformities affect the PIP and DIP joints, resulting in an abnormal finger posture, their characteristic appearances, their root causes, and critically, their treatment approaches are fundamentally different. Understanding these differences is absolutely paramount for precise diagnosis and effective management. A misdiagnosis here isn't trivial. It can lead to treatment that not only fails to help, but could potentially actively harm the patient by worsening the underlying imbalance.
Okay, let's break it down then. Start with the visuals. How do they differ fundamentally in appearance?
Right, let's start with the key differentiating visuals and the specific joint angulations. In a boutonniere deformity, as we've now discussed at length, the key feature is the PIP joint, the middle joint being permanently bent towards the palm. That's fixed flexion. Conversely, the farthest joint, the DIP joint, is bent back away from the palm, that's hyperextension. So visually, the middle finger joint bends in and the outer finger joint bends out, like a kink. If this affects the thumb, it presents similarly. The first joint, MCP, bends in, and the outermost joint, IP, bends backward.
And swan neck.
Now, contrast that sharply with the swan neck deformity. Here, the situation is essentially reversed at the PIP joint. The PIP joint is hyperextended, it straightens out excessively or even bends backward beyond the neutral straight position, while simultaneously the DIP joint is flexed, it bends inwards towards the palm. This combination creates that very distinct swan's neck appearance, with the excessively straight PIP forming the neck and the bent-down outermost finger joint forming what's often described as the head of the swan. Imagine that graceful, albeit pathological curve.
That visual difference immediately suggests another differentiator.
It does. It points to the affected digits. Boutonniere deformity, because its mechanism is primarily focused around the PIP joint, can impact any of the four fingers or even the thumb, as it only requires those two main interphalangeal joints for its characteristic pattern to emerge. Swan neck deformity, in contrast, can only impact the fingers. It cannot occur in the thumb. This is because it requires the presence of three distinct joints acting in concert: the metacarpophalangeal MCP joint at the base, the PIP, and the DIP for its characteristic swan-like bending pattern to manifest fully. The thumb, with its two phalanges and only one interphalangeal joint, simply lacks the necessary anatomical structure. So, if you see a deformity resembling this pattern in the thumb, it cannot by definition be a swan neck deformity. It must be something else.
Okay, visuals and digits clear. What about the underlying causes? Also different.
Fundamentally different causes, yes. For boutonniere deformity, as we know, the primary pathology lies in the disruption or dysfunction of the central slip of the extensor tendon at the PIP joint. This is frequently due to a traumatic injury, jamming, cuts, avulsions, or chronic inflammation systematically weakening that central slip, with rheumatoid arthritis being the classic example. It's an extensor mechanism failure at the PIP. For swan neck deformity, the typical initiating problem occurs after the structures on the palm side of the PIP joint, primarily the volar plate ligament tear, stretch out or weaken significantly. Again, rheumatoid arthritis is the most common underlying cause, as the synovitis directly damages the joint tissues and weakens this crucial volar plate restraint. However, swan neck can also result from other injuries, perhaps ones that tear the flexor tendon, which normally bends the finger, leading to an imbalance where the extensor forces overpower the flexion. Or sometimes it can result from tightness or spasm in the intrinsic muscles, or even from a mallet finger injury at the DIP that wasn't treated properly, causing secondary changes back up at the PIP joint. It's a complex interplay, often caused by excessive laxity in one area, the volar plate, allowing hyperextension and relative tightness in another, like the extensor mechanism or intrinsic muscles.
And how do the symptoms differ beyond just the look of the finger?
There are also subtle but important differences in the associated functional symptoms. Patients with boutonniere deformity will primarily struggle to straighten the affected digit actively. They'll find it nigh on impossible to extend their middle finger joint fully. The condition is often progressive if untreated, with the flexion contracture at the PIP becoming more pronounced over time, leading almost inevitably to stiffness and a fixed deformity that significantly impairs grip and overall hand function. For swan neck deformity, the main functional difficulty is often in bending the affected finger fully into the palm, particularly initiating flexion from the extended position. Patients might experience a noticeable, sometimes audible snap as the finger overcomes the hyperextension block when they try to make a fist, or they might feel as though the finger locks in the hyperextended position. Like boutonniere, stiffness can certainly develop if untreated, profoundly impairing hand function by making it difficult to grasp objects effectively.
Which leads us to treatment differences.
Exactly. The divergent treatment approaches really underscore the different underlying pathologies. For boutonniere, as we've covered, non-surgical treatment primarily involved that meticulous continuous splinting of the PIP joint in full extension for 6 to 8 weeks, aiming to allow the central slip to heal. Surgical options focus on directly repairing the central slip, or, in chronic cases, reconstructing it using tendon grafts to restore the extensor force to the middle joint. The focus is dorsal on the extensor side. For swan neck deformity, non-surgical treatment often involves using a special figure of 8 or ring splint, like an ovalate splint. This is specifically designed to correct the finger's position by preventing PIP hyperextension while still allowing DIP movement and some degree of PIP flexion. It blocks the back bending. Surgical interventions usually focus on addressing the volar plate laxity, perhaps by tightening it or by repositioning tendons like a lateral band relocation or flexor tendon procedures to restore balance and prevent hyperextension. If the PIP joint is severely arthritic and stiff, then joint replacement, arthroplasty, or fusion, arthrodesis, into a slightly bent, more functional position might be considered. The focus is often volar, or on balancing forces.
And finally, what about the outlook? Prognosis and reversibility.
That's another key difference. In terms of prognosis and reversibility, Boutonniere deformity, unfortunately, has a greater tendency to become permanent without timely and precise intervention. Once those soft tissue contractures become established, especially the PIP flexion contracture, they can be very difficult to fully reverse, even with surgery. Conversely, swan neck deformity, while still serious, is often considered somewhat more amenable to returning toward its original state, or at least significantly improving functionally, even if treatment is perhaps slightly delayed, although naturally, early intervention is always preferred for optimal outcomes in both conditions. The PIP hyperextension in swan neck can sometimes remain more flexible for longer. These critical differences in appearance, affected digits, root cause, functional deficits, treatment strategy, and prognosis really emphasize why meticulous differential diagnosis based on a thorough understanding of the pathomechanics is so absolutely vital in hand surgery. You have to know exactly what you're treating.
Professor, that stark comparison is incredibly illuminating. It truly underscores, as you say, why a keen clinical eye and a deep, nuanced understanding of these subtle but absolutely critical differences in pathology, presentation, and treatment are paramount for effective management and ultimately for achieving the best possible patient outcomes.
Absolutely. Precise diagnosis is truly the cornerstone of effective hand surgery. It's simply not enough to recognize that there is a deformity. One must strive to understand the exact underlying mechanism, the specific structures involved, and the cascade of events that led to it. Only with that granular level of understanding can we then tailor our treatment strategies, whether conservative or surgical, to truly address the specific pathology rather than just managing the visible presentation. And that precision ultimately is what allows us to achieve the best possible functional and aesthetic outcomes for our patients, helping to prevent long-term disability and restore as much as possible the intricate, vital functionality of the human hand. It really is the difference between merely treating a symptom and truly healing the underlying disruption to that delicate balance.
Today, we've taken a truly deep dive into the complex world of acquired hand deformities. We've particularly dissected Boutonniere deformity, unraveling its unique pathology, that fascinating cascade of anatomical changes, the vital diagnostic nuances, including the invaluable Elson test, and the varied treatment pathways available, from that meticulous splinting regimen right through to innovative surgical reconstruction using autologous grafts like the palmaris longus. We also took care to highlight the crucial distinctions from commonly confused conditions like swan-neck deformity, underlining how seemingly similar presentations can demand fundamentally different clinical approaches. I think our discussion today really underscores the immense importance of maintaining a keen clinical eye, a high index of suspicion, and a comprehensive understanding for all orthopedic professionals navigating these often complex and challenging conditions. Timely and precise intervention based on accurate diagnosis is truly the key to preserving the intricate function of the hand and restoring the quality of life for our patients. If you found this deep dive informative and valuable for your practice, please do take just a moment to rate and share it with your colleagues. It genuinely helps us reach more dedicated professionals like you. Professor, thank you so much once again for sharing your invaluable expertise and insights with us today. It's been incredibly enlightening.
Thank you for having me. Ultimately, maintaining the delicate balance and intricate function of the human hand requires not just a solid foundation of anatomical knowledge, but also, I think, a deeply nuanced understanding of how these diverse pathologies disrupt that balance. It demands precision, doesn't it? Precision in both diagnosis and intervention, always aiming for optimal patient care. The hand truly is a microcosm of the body's incredible biomechanical complexity and a constant source of fascination.
A perfect final thought. Thank you again, and thank you all for joining us on the Deep Dive Ortho. Until next time, keep learning, keep questioning, and keep innovating.